Bismillahirrahmanirrahim. Today we are going to discuss the prostate cancer. We know that the most common type of cancer that occur in prostate is the cancer that arises from the glandular epithelium of the prostate known as the prostatic adenocarcinoma. The prostatic adenocarcinoma is I said is the most common type of prostate cancer and 95% of the prostate cancers are prostatic adenocarcinomas. So adenocarcinoma is the malignant tumor that arises from the glandular epithelium of the prostate gland. By malignant tumor we mean that it can invade locally and it can also give rise to metastasis to the other organs of the body, particularly the bones, vertebra and the hip bones. We know that the prostate gland is the accessory sixth gland of the male reproductive organs, and the prostatic secretions make the male semen alkaline, so that it normally it may have a better survival in the semen during inside the acidic medium of the female vagina, and it gives a longer life to the spermatozoa. Moreover, the prostate secretes uh, nutrients that nourishes the spermatozoa, and the prostate also secretes the prostate specific antigen, which is a protease enzyme, and that will dissolve the clot semen so that the spermatozoa can freely move in it. The prostatic urethra also receive the ductus deferens or vas deferens that carry the mature spermatozoa from the epididymis of the testicular tissue, and the seminal vesicle which provide fructose and other nourishing uh, materials to the semen that provide nourishment to the spermatozoa and form the major portion of the male semen. We know that the prostate is a small gland about the size of a walnut or chestnut, and it is located under the urinary bladder and in front of the rectum. The urethra is the common passage for the male semen during ejaculation, as well as for the urine from the urinary bladder. The part of the urethra that passes through the prostate gland is known as the prostatic urethra. And the prostate gland itself is a compound tubulo-alveolar gland. It is surrounded by a connective tissue capsule that contains fibrous tissue and smooth muscles, and from this connective tissue capsules, septa arise and divide the prostate gland into compound tubulo-alveolar glands into a large number of acini that contains the glandular tissue. The ductus deferens, the final portion of the ductus deferens, is dilated and it forms the ejaculatory duct and receives fluid from the seminal vesicles, which are small glands located on either side of the prostate gland. Additionally, there are also bulbourethral glands. A pair of bulbourethral glands are bulbal glands that mainly provide mucus that help to moisturize and lubricate the male semen, and so that the uh, for the performance of a successful sexual act and also for giving life and nourishment to the spermatozoa that are ejaculated during the ejaculation process. We divide prostate into different zones, anatomical zones. The largest one is the posterior, outermost posterior zone known as the peripheral zone. And this zone contains about 70% of the glandular tissue. We know that the prostate is composed of mainly glandular tissue and the supporting tissues are supporting connective tissue which is made of fibrous tissue and smooth muscles. So this portion, the largest one, the posterior peripheral zone, is the largest portion of the prostate, and this zone contains mainly the prostatic glandular tissue, and this is the common site for the prostatic adenocarcinoma. Now, second to the peripheral zone, there is a central zone which also has the transitional zone, and the transitional zone of the prostate immediately wraps and surrounds the urethra, and this is the common site for benign prostatic hypertrophy, and for this reason the problems with urination or obstruction to urination occurs very early in benign prostatic hyperplasia when we compare it to the when it occurs during prostatic cancer. Since the common site for prostate cancer is the peripheral outermost posterior zone, so it is a little away from the urethra and it takes time to cause compression or obstruction of the urethra, giving rise to the specific symptoms. The central zone also carry the ejaculatory duct which carry fluid from the seminal vesicles and join the ductus deferens, and the interior portion of the prostate, it is mainly composed of smooth muscles and fibrous tissue, and this portion has very little glandular tissue, and during the digital rectal examinations that we usually made in benign prostatic hyperplasia and prostatic cancer, so if the prostatic cancer is in the central zone or transitional zone, it cannot be easily felt by digital rectal examination. On the other hand, benign prostatic hypertrophy that mainly occurs in the transitional zone cause early symptoms of urinary obstruction, hesitancy, and uh, incontinence, and passing inconstant urine stream. So the symptoms comparatively occur early in benign prostatic hypertrophy as compared to the carcinoma of the prostate, which will be felt through digital rectal examination, particularly if we feel a hard, solid lump with our finger when we are doing the digital rectal examination. We know that the sperm, they are produced in the seminiferous tubules of the testicular tissue, and from the seminiferous tubules the spermatids, they are transferred into the retris testis, and then into the epididymis where they undergo maturation, and the mature sperms then travel through the ductus deferens or vas deferens from the epididymis, and on its way it joins the uh, ejaculatory duct from the seminal vesicle and joins the prostatic urethra, opens into the prostatic urethra. The prostate gland also secretes prostatic secretions that contain uh, acid phosphatase and particularly the prostate specific antigens that cause dissolution of the clot semen, and the bulbourethral glands on either side of the urethra, they provide mucus which the main function of this mucus is lubrication. They are also known as the Cowper glands. So the sperms produced in the testicular tissue seminiferous tubules that are carried by the vas deferens from the epididymis and into the in the ejaculatory duct and prostatic urethra, where it receives prostatic fluid from the prostate and semen from the seminal vesicle, and during the sexual intercourse these the male semen is ejaculated to the exterior into the female vagina through the external urethral opening, which is also a site for the urine. But during ejaculation, the sphincter closes the urinary bladder and only semen is ejaculated. Later on, after ejaculation, when the sphincter opens, the person can pass urine. So, coming to the causes of prostate cancer, as we know that the exact cause of any cancer uh, is not very well understood, but certain risk factors uh, we can identify. So the androgens, particularly the testosterone, which is secreted by the Leydig cells of the testicular tissue, and also some testosterone and androgens are secreted by the zona reticularis of the adrenal gland. The testosterone or androgens has got very important role in the acceleration and propagation of the carcinoma prostate. So we discuss it in a little detail, and the initial major problem that occurs in carcinoma prostate is the acquired somatic mutations in various genes that control cell cycle. And when these genes, particularly the oncogenes, and the tumor suppressor genes, when they are mutated, they allow uncontrolled cellular division and proliferation. Heredity also play a role in the carcinoma prostate, and sometimes the prostate cancer occur in families and close relatives. So from this we can say that this role is also played by certain genes. Environment, the role of environment in prostate cancer is uh, uh, little understood, but certain diets, low fiber diets, high protein diets, they may increase the uh, incidence of the uh, prostate cancer. So the prostate cancer is actually the prostatic carcinoma and prostatic adenocarcinoma. But here I want to mention that other types of rare cancers can also occur in prostate gland. For example, the transitional cell carcinoma, the transitional cells are particularly found in the urinary bladder and the part of the urethra that passes through the prostate gland and is surrounded by the transitional zone, so that can be a site for the transitional cell carcinoma. And also sometimes, but rarely, tumors from the neuroendocrine cells present in the wall of the prostatic glandular tissue. These neuroendocrine cells can give rise to small cell prostatic uh, cancer, but the small cell prostatic cancer and transitional cell carcinoma is rare in prostate, and the most common tumor of the prostate is the prostatic adenocarcinoma. So this prostatic adenocarcinoma, actually it is adenocarcinoma. By that we mean that it arises from the glandular epithelium of the prostate gland. Most commonly, and the most common site for prostatic adenocarcinoma is the peripheral posterior zone, which contains most of the glandular tissue of the prostate. So this is the most common zone. However, sometimes the carcinoma may occur also in the transition zone, but it is only 20%. The risk factors, the known, very well known risk factors for prostate cancer is that it usually uh, uh, directly proportional to the age, and it is a cancer of the old age that usually occurs after 50 years of age, and as the age increases, the frequency of the carcinoma prostate increases. Obesity is also said to be a risk factor for the prostate cancer. Now here uh, we it is important to mention the relation of the androgens and the prostate cancer. We know that the prostatic cell growth is under the control of mainly dihydrotestosterone. The Leydig cells of the testicular tissue secrete testosterone, but testosterone is comparatively less effective in causing growth and proliferation of the prostatic glandular tissue. But this testosterone is converted by the enzyme produced by the prostate known as the 5-alpha reductase. And this enzymes will convert this testosterone into a potent androgen known as the dihydrotestosterone, which is 10 times more potent in causing the prostate cells to live long and to multiply. The role of the androgens on prostatic growth is evidenced by the fact that if a male is subjected to archiectomy in which the testicular tissue is removed and the source of androgen is nearly finished, so in this situation the prostatic cells, they will undergo apoptic cell death and they are unable to survive. So by this we mean that the androgens and particularly the dihydrotestosterone found by the conversion of the testosterone by the enzyme 5-alpha reductase has got very specific and important role in prostatic hyperplasia and hypertrophy. And since the androgens, they do not initiate the prostatic cancer, they do not initiate the prostatic cancer, but they act just like we spray petrol on fire. So they will rapidly and potently accelerate the growth of the neoplastic cells. And therefore, in prostatic carcinoma, the first attempt after medical and hormonal therapy is to remove the testicular tissues by doing the archiectomy to finish the source of testosterone, and this has got a very prominent effect on slowing down the growth of the cancer cells. But unfortunately, with the passage of time, what happens that additional genetic mutations occur in prostatic glandular cells, and these additional genetic mutations, they make these cells to divide and proliferate independent of the androgens. And this is the reason that why sometimes when we even use the anti-androgen drugs, and at this time if even we do archiectomy, we cannot slow down the growth of the prostatic cancer. This is because the additional genetic mutations cause the prostatic cells irresponsive to the effect of the androgens, and at this stage without the androgens, the prostate cancer cells, they achieve an automaticity, and without the androgens they proliferate and grow. Now important points about the carcinoma of the prostate, that it is a cancer of aged people, and there are variations. One person may have prostate cancer but no symptoms and no problem. That may be an indolent disease. And most of the time, people with prostate cancer die from some other disease, die from some other cause. So, in this situation, the prostate cancer is producing a very mild disease. However, at the other end of the parameter, the prostate cancer may be so aggressive and so rapidly growing and undergoing metastasis to bones, that it will result in a rapidly fatal tumor. So we must know these variations in the severity of the disease. In some patients, the disease is very severe, while in others it is just an indolent illness. As I mentioned that in addition to adenocarcinoma, the other rare cancers known as the transitional cell carcinoma and small cell prostate cancer arising from the neuroendocrine cells may also occur in the prostate, but the major cancer is the prostatic adenocarcinoma. And the prostatic adenocarcinoma, the most common zone for the prostatic adenocarcinoma is the largest one, which is the peripheral posterior zone of the prostate. And in this region, the prostate cancer form hot, solid nodules that can be easily felt by uh, uh, digital rectal examination. Now, morphologically, there are different patterns that are commonly seen during the microscopy. In some biopsy specimens and tissue slides, we will see very well differentiated glandular structures, and they are very close to the normal prostatic tissue, while in other areas of the same patient, we will see very poorly differentiated neoplastic cells. By that we mean that even they lack the glandular pattern. So normally we see the moderately differentiated adenocarcinoma that may form well-defined glands. And it is important to mention that the glands that are formed by the neoplastic prostatic cells, they are smaller than those glands which are formed by the benign prostatic hypertrophy. And in benign prostatic hypertrophy or hyperplasia, both the layers, the basal cells and columnar epithelial cells, both the layers are present, and they form papillary projections that project into the lumen of the glandular tissue. But in prostate cancer, there will be a single layer which is mostly formed and contain the neoplastic columnar epithelial cells, and there will be no basal layer which is seen in the benign prostatic hypertrophy. In severe cases, the malignant glands, they are crowded together, and unlike benign prostatic hyperplasia, they do not have the branching and papillary pattern or folding or projections in that in benign prostatic hyperplasia project into the lumen of the gland. It is also said that in most cases, 80% of cases in which we suspect carcinoma of the prostate and we remove the prostatic tissue or biopsy, we may also see a precancerous stage in the form of presumed precursor or precancerous lesions. And this type of presentation in the histopathology is known as the prostatic intraepithelial neoplasia. So this type of situation can be seen where there is no full grown cancer, but this can be considered as a precancerous condition and is known as the high-grade prostatic intraepithelial neoplasia. Now in this picture we can see the prostate cancer in the posterior peripheral zone of the prostate, and we can identify on the other side, on the right side, the normal prostate which contains well-defined glandular patterns, but this is a region which is solid, hot, and it doesn't contain any glands. So this portion which is uh, uh, prostate cancer, is solid and comparatively wider, and the normal portion of the prostate where cancer has still not reached it will be spongy and contains the glandular tissues that are visible. So in this slide we can see the neoplastic glands, which are smaller and crowded, and here we will see the normal prostate glands, which are comparatively larger, and they surround the cancerous small size glands. Now symptoms, as I said that initially the prostate cancer caused no symptoms. When we compare it to the benign prostatic hypertrophy, which commonly involves the transitional zone and causes early compression of the urethra, so benign prostatic hypertrophy or hyperplasia cause symptoms more earlier than prostate cancer, because the prostate cancers are mostly located in the posterior peripheral posterior zone, and since this zone is away from the urethra, so the tumors, as we know that it's grow slowly, and it is the time when the tumor will grow quite large to cause compression of the urethra and problems in urination. However, with over time, the tumor will grow, or it may compress, or it may actually invade the urethra or the urinary bladder. And this is the time when it will be causing difficulty in urination. Obstruction to the passage of urine, which may result in hesitancy, narrow urine stream, sometimes severe pain, and bleeding, blood in the urine. And this type of symptoms are usually experienced during passing urine and during ejaculation. The malignant prostate cancer, when we say malignant, by that we mean that it can invade locally and it can get metastasized. And it usually, the in late stages, it will get metastasized to the bones, particularly to the vertebra and the hip bones. And uh, in patients with advanced prostate cancer, the patient may present with problems in the vertebra or bones, for example, for severe lower back pain. Now, for making the diagnosis of the prostate cancer, first of all, if we suspect, we listen to the sign symptoms of the patient and we do a digital rectal examination. In here, we insert lubricated finger after wearing proper antiseptic gloves. We insert finger and we feel for the prostate. And uh, if we feel a hard, solid mass here, we know that the prostate gland is located, the posterior portion of the prostate gland is immediately located in front of the anterior wall of the rectum. So here we can palpate the prostate cancer. But if the prostate cancer lies in zones other than the peripheral posterior zone, for example, if it involves the transitional zone, if it involves the central zone, so in that situations we may be unable to palpate it with a finger. So we may also do transrectal ultrasound, and we may also do magnetic resonance imaging to visualize the prostate. And the very important is the measurement of the prostate specific antigens. The prostate specific antigen, though it is organ specific and not cancer specific, but it can give us very valuable information. For the diagnosis of the prostate cancer, we use the Gleason scoring and grading. And this diagnostic approach for prostate cancer, we can get it from histopathology that we will prepare from the biopsy. We will take biopsy and we will prepare histopathology slides. So What is Gleason scoring and grading? Here we see that mostly in the prostate tissue and even in the biopsy that we have taken, there will be different pictures and presentations of the cancerous tissue. In some area, there we may see well differentiated glandular structures, while in other areas we may see under the microscope the area where no glandular structure can be identified. So the most one that we see is the primary site. For example, if we examine 5 slides and in more than 3 slides we may see a particular pattern, we label that pattern as the primary. And then in that primary pattern, we divide it into grades 1, 2, 3, 4, and 5. In grade 1, we have very well differentiated glandular structure. And as we go from 1 to 5, the differentiation is lost. So we divide our histopathology examination into 2 sections: the most frequently seen pattern and then the secondary most frequent pattern. And we divide these 2 patterns into grades. So we have 2 grades in our histopathology examination, one which is the most frequent and very common in the prostate gland, and the one that is second to the most common, and we label that as the secondary pattern. Now we divide both the patterns into grades 1 to 5. The grade 1 will be well differentiated glands, and grade 5 will be the very poorly differentiated glands, and sometimes even no glands can be seen. Now then we, for example, if in the primary pattern, if we have the number 3, which will be roundabout mildly differentiated glandular pattern. And if in the secondary pattern, if we have the number 5, undifferentiated, poorly differentiated glandular structures, so we add these 2 numbers from the primary pattern and from the secondary pattern, and then we get the Gleason score. And the high Gleason score indicate high grade cancer, poor response to the treatment with poor prognosis. Sometimes the prostate tissue may contain even one pattern. There is no secondary pattern. So in that situation, we directly take the grade. If it is 1, 2, 3, or 4, and it is the primary pattern, and we put this Gleason score into the Gleason scoring and grading, but the high score indicate high grade and poor prognosis. The treatment options for the carcinoma prostate include hormonal treatment. For example, we may use 5-alpha reductase inhibitors to prevent the conversion of testosterone into dihydrotestosterone, which will rapidly accelerate the growth and multiplication, proliferation of the prostatic tissue. So it can help us in to shrink the prostate gland, and sometimes even prostatectomy may be needed to remove the prostate gland, but it will be effective only if there is no metastasis. And we also do archaeectomy to remove the testicular tissue so that to finish the source of the androgens. In advanced cases, we are left with only chemotherapy and radiation therapy. So by summarizing what we said, that prostate cancer affects people commonly above 60 years of age. It is a disease of the old age. There can be individual variation. A person with prostate cancer may have very mild disease and the other person may suffer from aggressive fatal disease. The most commonly involved portion is the posterior peripheral outer zone, and microscopically there is variable differentiation. Sometimes the prostate cancer may contain well-defined prostatic glands, while in other regions or in other cases, even in grade 5, even the prostate glandular structures cannot be identified and the very poorly differentiated or undifferentiated cells may be seen, and the basal layer is lacking under the microscope that is normally present in normal prostatic tissue, and therefore the neoplastic glands, they are lined by the single layer of columnar epithelial cells. And we may also use the Gleason system by examining the primary and secondary patterns. The primary is the most frequent and most common, and secondary pattern would be the second to the primary, and then by the Gleason system of scoring and grading we can give stage to the prostate cancer. And the prostate specific antigen levels, they are increased, but since it is not very specific and it is also increased in benign prostatic hypertrophy, so we can say that this prostate specific antigen is organ specific but not cancer specific. And however, it may give us very valuable information. For example, if we are treating a patient and if the prostate specific antigen level is uh, falling, we can say that the treatment is effective. And if the prostate specific antigen suddenly arises in a patient under the treatment for prostatic carcinoma, we can say that this is the recurrence of the prostate cancer. Prostate cancer in advanced cases involves the lymph nodes, and it can metastasize to other organs, particularly to the bones, and the hip bone and the vertebra are the common sites for the metastasis of the prostate cancer. But at this stage, we are left with very little treatment options. But for example, we can do radiation therapy, chemotherapy, and uh, this will be the very advanced stage of the prostate cancer. Thank you very much.